So this is Dr. Bhaumek. I'm ex-professor of pediatrics, University of South Alabama College of Medicine. I was also chief of the division of pediatric endocrinology in Children and Women Hospital at University of South Alabama, Mobile. I also in United States Air Force and retired as a colonel medical corps. Those who are following my lecture series, by now you already know my introduction. So without further ado, I like to today discuss some very interesting cases of Down syndrome with thyroid problem. And as I said here, this is coexistence of Hashimoto's thyroiditis and Graves' disease in children with Down syndrome. And it could be a management challenge. We all know that thyroid dysfunction is more common in children with Down syndrome compared to the regular children. Indeed, you can say that it's at least 10 times thyroid dysfunction is 10 times more common in children with Down syndrome. And indeed, if you look at the congenital hypothyroidism, the incidence of congenital hypothyroidism is also somewhat higher in children with Down syndrome. So most of the time, the acute thyroid dysfunction occurs around the age of puberty, but it could be early or it could be late, anytime in their life. And most common thyroid dysfunction is hypothyroidism, which is due to autoimmune or Hashimoto's thyroiditis. We also know the Graves' disease incidence is also somewhat higher than the general population for patients with Down syndrome. Now, we now know that there is something very interesting about the thyroid disease or dysfunction that occurs in the Down syndrome, that they can have the both component of Hashimoto's thyroiditis and Graves' disease. It could be together, or they can switch, and they are what we call the metamorphosis of the gland. And the Down syndrome children are known to do that. And the adult literature, it is quite clear also, they have seen the same kind of problem. So, although I have managed quite a few cases, but 3 cases that I am going to discuss with you, and this was the beginning. So, first case, as you will see, that we kind of mess up a little bit, but after that we knew how to do this thing and did pretty good. Now, I also presented this case report to Southern Pediatric Endocrine Society meeting in Clearwater, Florida in 2008. So, as I said, that I'm going to present 3 cases, and all had trisomy 21, and they present with hyperthyroidism both clinically and laboratory wise. And we did determine the antibodies, and we should be determined in all cases of thyroid dysfunction. So all three patients had antibody titer which is present in Hashimoto's thyroiditis as well as in Graves' disease. So I am not going to discuss all the details, signs, symptoms and so forth because you guys are all familiar with the typical signs symptoms of hypo and hyperthyroidism. But I'm going to discuss the salient features so that we can cover a little bit more in terms of discussion. So let us start with patient 1. Patient 1 was a 12 years old female. Beside thyroid disorder, also had type 1 diabetes 3 years prior to, at the age of 9 years or 3 years prior to the presentation with thyroid dysfunction, and presented with typical symptom of hyperthyroidism, and diabetes is poorly controlled, and she indeed have goiter, and there was no exophthalmos, but all other clinical symptomatology, tension, tremor, tachycardia, and by looking you know that this hyperactivity, these are all consistent with Graves' disease. And initially when you do that thyroid test, it did show that TSH is really suppressed, 0.05, and I put the normal value in the bracket. Thyroid TPO is thyroid peroxidase antibody, which is a hallmark of autoimmune or Hashimoto's thyroiditis, was present in very high titer, more than 1000 IU per ml. And thyroid antibody, thyroxine thyroxine binding globulin antibody, TBG antibody, was 320, and this is thyroglobulin antibody, anti-thyroglobulin antibody, which is also high, and thyroid stimulating immunoglobulin, which is a hallmark, the laboratory hallmark of Graves' disease, was 12 milliequivalent per liter, and the reference is less than 2. We did an iodine uptake on this patient, which was 32%. The reference is 5 to 15%. This somewhat increased uptake do suggest the hyperactivity of thyroid gland and the which disease was predominant at this stage. So that time we started this patient all PTU, the recommended dose, and thyroid function was followed very carefully monthly. I have not put all the thyroid test results that we did, but only the one that is going to be helpful for the purpose of our diagnosis and the discussion. So this patient rather was sensitive to PTU, and after 5 months developed clinically and laboratory-wise hypothyroid. Her free T4 was 0.3. TSH has gone up to 42, and at that point we discontinued the PTU and started following. 3 months later, she came with hyperthyroidism again. This time her free T4 is 2.9. TSH is 22, and thyroid peroxidase antibody was more than 1000, and thyroid stimulating immunoglobulin was 7. The I apologize for the TSH level. It should be TSH level of less than 0.2. So this is a print mistake, 0.2. So at this time we started on methimazole and the low dose of thyroxine, since the patient has both antibody for Hashimoto thyroiditis and Graves' disease. So around 58 weeks follow-up, the patient was clinically hypothyroid. Free T4 was 0.5, TSH was 29, and TSI is less than 2. Thyroid peroxidase antibody continued to be more than 1000 IU per ml, and thyroglobulin antibody was more than 300 IU per ml. At this point, we discontinued the PTU and started on and continued with the Synthroid. Did increase the dose from 0.25 to 0.5 milligram daily and 0.05 milligram daily, and no recurrence of hypothyroidism up to 4 years follow-up. However, knowing fully well that this disease can switch back and forth, time to time we did continue to check thyroid stimulating immunoglobulin together with thyroid peroxidate and antithyroglobulin antibody. And again, after 4 years, patient was on 0.1 milligram of levothyroxine and continue to be followed by our clinic. So this one I have 4 years follow-up data. Patient 2 was a 9 years old male with a trisomy 21, presented with signs symptoms of hypothyroidism, goiter, weight loss, tachycardia. This child was also on Ritalin for the diagnosis of ADHD. Laboratory examination finding shows free T4 is very high, 3.8, and TSH is suppressed to 0.03, and the normal value that I have given in the first cases, so I do not want to repeat those. But thyroid peroxidase antibody was 1000 IU per ml, antithyroglobulin antibody was 500, and TSI was 9 milliequivalent per liter, and reference range is less than 2. It's important to know that this is high TSI. This patient we started on methimazole. We recommended 500 milligram 3 times a day, and thyroid function test was checked about monthly for about 9 weeks, and within 8 to 9 weeks that thyroid function T4 came to the normal range with mild elevation of TSH, and at this point we reduced the methimazole to 2.5 milligram lower dose and continue to follow. At 28 weeks, around 28 weeks, thyroid function revealed that free T4 is 0.7. The reference is 0.8 to 1.8. TSH has gone up to 7 MIU per ml. Thyroid peroxidase antibody is 985, which is elevated, which remain elevated, and thyroglobulin antibody is 380 IU per ml. TSI is positive, present, again 5 milliequivalent per ml. The patient clinically was euthyroid. the methimazole was discontinued to 2.5 milligram, reduced to 2.5 milligram, not discontinued, reduced to 2.5 milligram daily. And since TSI is still positive, thyroxine was added to the regimen this time. And we started with a low dose of 12.5 microgram. Then we did increase slowly and gradually. About 42 weeks, our pre-T4 was 0.65, just slightly low. TSI has gone up to 22. Thyroid peroxidase antibody was 320. Thyroglobulin antibody was 289, and both of them are positive. However, TSI was undetectable, which is antibody for Graves' disease undetectable. So at this point, we actually discontinued the methimazole, and thyroxine dose was increased to 37.5 microgram daily, which was further increased to 50 microgram after 6-month visit. And this patient is followed. And as far as we know, up to 3 years follow-up in regular pediatric clinic, that she is still hypothyroid, but Graves' disease has not recurred and on levothyroxine. Number 3 patient is a 13-year-old female with Down syndrome. She presented with goiter and all symptoms of thyrotoxicosis. Her free T4 was 3.51 and TSI 0.1 MIU per ml, and her thyroid peroxidase antibody was more than 1200. Thyroglobulin antibody was 660 IU per ml, and both of them are significantly increased. She had a very easily palpable goiter. We did measure the thyroid stimulating immunoglobulin, which is a marker for Graves' disease, was a 14, which is significantly elevated. Normal is less than 2. We also did her uptake, which was elevated to 29%. She was started on methimazole, and thyroid function was monitored once a month, and the dose was adjusted depending upon the level of thyroid hormone. And her TPO, TSI, and thyroid antithyroid antibody were checked in 6 months. And 18 months later, the patient became hypothyroid, and in between we have been checking the thyroid function and thyroid antibody. Her TSI level was elevated, 12. Her free T4 was low, 0.2. And her thyroid peroxidase antibody is still positive with 600. Thyroglobulin antibody is 94. And TSI is less than 2 MEQ per liter, which is negative. Thyroglobulin antibody is still a positive in a low titer, is level in our lab was less than 30. So patient started on thyroxine 50 microgram, and we checked the thyroid function test at regular interval, and thyroid dose was increased to 0.1 milligram. This patient was also, we have a 4 years data, follow-up data in our endocrine clinic, and she has not developed hyperthyroidism, but continue to get the thyroxine 0.1 milligram a day, and thyroid antibody continue to be positive at low titer, but TSI, which is the marker of Graves' disease, was continue to be negative. So the observation is that all these patients who presented with hypothyroidism, hyper, developed presented with hypothyroidism, develop hypothyroidism rather rapidly. Normally, in a patient of Graves' disease alone, it takes longer time to make the patient euthyroid. The presence of elevated TSI resulted, and if the antithyroid medicine was discontinued on the basis of hypothyroidism, and when TSI is still positive, result in recurrence of hyperthyroid state. So the optimal management in our judgment is the antithyroid medication initially with the addition of thyroxine once the patient develops euthyroid or hypothyroid state. So patient initially should be treated for Graves' disease by antithyroid medication, and the moment the patient becomes hypothyroid, and if the TSI is still there, that suggests it is a switch or it's a coexistence, and at this point it will be a good idea to keep the low dose of levothyroxine and also antithyroid medication just to continue to see at what point TSI will be negative. And antithyroid medication was successfully discontinued when TSI was no longer elevated. Thyroxine binding thyroid peroxidase antibody, thyroglobulin antibody persisted for a long time. Two patients we have follow up to 4 years, as we mentioned, and even then the patient has got thyroid antibody, anti-TPO and anti-thyroglobulin antibody positive, although at somewhat lower titer. And we have a belief that this patient is now going to need thyroid medication for the rest of their life. So how do we differentiate between this Graves' disease, hashimotoxicosis, and coexistence of this condition? Graves' disease is rather easy. It's a diffuse enlargement of the thyroid gland. About 50% plus time they develop exophthalmos. Radioactive iodine uptake is very high. TSI, thyroid stimulating immunoglobulin, is also very high. But not be surprised that there may be positive thyroid peroxidase and anti-thyroglobulin antibody, but usually somewhat lower titer than seen in autoimmune or Hashimoto's thyroiditis. And Graves is clear cut, and that usually this patient takes a longer period of time to remit their hyperthyroid state. Hashimotoxicosis is a condition which is seen in the initial phase of Hashimoto's thyroiditis due to the spillage of the hormone because of the thyroid destruction by the autoimmune process. The patient might present with a painful goiter, low-grade fever, and they will have negative thyroid stimulating immunoglobulin. And they usually have positive thyroid antibody for Hashimoto's, but do remember sometimes that initially a TPO-ATG may be negative, but in 6 month time they will be positive. So in this condition, the treatment is hardly necessary excepting maybe beta blocker, and in about 6 to 10 weeks they become euthyroid, and then they remain euthyroid for a while, and then either they remain euthyroid, but by far majority of them will develop hypothyroidism with positive thyroid antibody. And this patient TSI will be negative. Now, coexistence of Hashimoto thyroiditis and Graves' disease in the same gland, and which is sometimes indistinguishable if the initial phase of presentation is hyperthyroidism. As we have seen in our patient that iodine uptake will be high, and thyroid stimulating antibody, thyroid peroxidase antibody, antimicrobial antibody, or what is called thyroid peroxidase antibody, they are all positive. And children and adults with Down syndrome known to do this one more than any other patient, and they call metamorphosis of the gland or switching mechanism. So therefore, if somebody is being treated mostly for hyperthyroid state, do check the antibody for Hashimoto's autoimmune. And the patient usually, if it is a coexistent, then hyperthyroid phase does not last long and they will be sensitive to antithyroid medication. So once become hypothyroid, if the TSI is still present, do the combination therapy. Antithyroid medication, at the same time low dose of levothyroxine. And levothyroxine can successfully be antithyroid medicine can successfully be discontinued once TSI level is no more there. And so thyroid antibody in this situation is a very good determining factor what to do next. And again I'm repeating that once the TSI has gone, then one can stop the antithyroid medication and put them on thyroid medication or continue with the thyroid medication. And even this patient become negative for TSI, but do check the TSI level time to time and don't be completely surprised if that hyperthyroid may be back in many years. And that has been reported, and the literature do suggest that, so one has to be careful. Therefore, coexistence of both these conditions is more common with the patient with Down syndrome, as I have mentioned, and again the determination of antibody iodide uptake is going to be helpful to make the distinction between two, and proper diagnosis will help you to formulate the better plan of medical management. And as I have mentioned already, the checking the autoantibodies for both Hashimoto's and Graves' disease should be done time to time, even the patient is on only levothyroxine or thyroxine, since the gland may switch. So this at present time that there are many publications that I saw, and they have indeed came with the same kind of conclusion, and they have also similar problem in the beginning for their management. So they go through UEO mechanism that if you stop the antithyroid medication and have not checked the antibody and then discontinue antithyroid medication, and they will be back in a couple of months, and then we'll have to go start again. But the most important point that I want to make, if you check the antibody, if TSI is there, continue with antithyroid medication, maybe at lower dose, and even the patient is hypothyroid, a lower dose of thyroxine should be continued until the TSI is no more there and the patient thyroid function will dictate and what direction the patient will be. My belief is that almost all of them are going to develop or will remain with the diagnosis of Hashimoto's thyroiditis or autoimmune thyroiditis and need the replacement of thyroid hormone for the rest of their life. Thank you very much. I'll see you in my next lecture.